Welcome back.
Oh, what? Oh, we're started.
Hello and welcome to Prescribe Orly.
We're gonna get a copyright strike on that one. It's like
You're
my
not
singing
that
was
much
that
of a
perfect.
god. Flip, here we go. So today we're going to be
Drake, sign me.
forgot to do the intro. So yep, I did do the intro, did I?
I don't know.
Welcome to Prescribe Orly. It's your host Shatner, and
This is a travesty.
And this is Chris.
Do we need to start this one again?
no, absolutely not.
Cool.
So today we're going to be discussing about psoriasis.
Okay. Yeah, so this is the podcast where two idiot medical students discuss a topic and learn the topic ourselves.
Yeah,
We're not here to teach us because we know absolutely nothing. You guys can join in.
No. You need to sell yourself. We know absolutely
Everything.
50% of things.
50%.
Yeah.
51% to be optimistic, because you
be
round
optimistic. You only need 50% to pass.
Yeah,
medicine, so-
51% means that you round up, so we basically know everything.
Yeah.
Okay.
So come kick back, relax, and enjoy this podcast or vidcast with us.
Vidcast. Ooh.
That's a good word.
That was a nice word.
Capitalizing on that word.
Nice.
So today's topic is psoriasis, and
So Shatner, what is psoriasis?
here we
Teach
go.
me, boy.
So psoriasis is a common chronic inflammatory papillosquamous disorder.
Nicely
I read that off the screen.
Yeah, nicely read.
It's pretty much characterized by like scaly,
well demarcated scales.
scaly,
typically occur on the extension.
relapsing remitting course.
Oh.
So
What's that mean?
it means it relapses and remits.
Means it comes back.
Exactly, relapse. It means comes back.
It comes back, goes away, comes back, goes away. Yeah. Basically what you said.
So it's a common benign inflammatory condition. There's quite a lot of people out there with psoriasis.
Yeah, about 2 to 3% of the population.
3% of the population, yeah. So bit of a disclaimer, I know it's quite far into the video. We don't try to make fun of the condition. It's the way we learn.
Yeah.
And
our comedy is mainly at ourselves. Don't take our comedy as a way of us making light or being flippant about because we know these are conditions.
Nasty conditions
that
and like
people do suffer from for their life. So
yeah.
just as a serious side note.
And just be mindful of it whenever you start watching it as well.
Yeah.
Superb.
When you're on the wards and stuff as well as medical students. Psoriasis is caused by the T cell driven inflammatory response for the epidermis.
Yeah. And what cytokines are involved, Chris?
There's TNF alpha. Mm-hmm. No, it's not. Is it? Well, TNF.
Yeah. What does TNF stand for?
Tumor necrosis factor.
Oh, he's on fire.
Oh.
Yeah.
Go me. But yeah. So triggers of psoriasis.
Whoa, you still haven't said the cytokines.
I don't know them.
Okay. So
there's too many numbers.
There's interleukin 12, 23, and 17 are involved in. They're the pro-inflammatory cytokines.
Okay, involved in psoriasis.
Yeah. And there's a hyperproliferation of keratinocytes and angiogenesis, which means there's new blood vessels being formed.
Look at you go. On fire.
This is what I'm talking about.
Future dermatologist in the making right here.
Yeah.
Okay. So
triggers. So if you're stressed,
that was really weird, like symbiosis there. Like
this is what I mean.
Yeah.
This
vidcast becoming one.
Becoming one.
We spent too much time together.
I don't. Too much imagery of becoming one there. So yeah, stress, alcohol, smoking. So alcohol and smoking is like a physical sort of stress you're putting your body through. So yeah, stress is the biggest thing for
causes your sort of relapses of the condition or exacerbates the condition. Then also you have your Koebner phenomenon, which I actually remember this as so typically this occurs when you have physical trauma to that area. And it's a phenomenon where that physical trauma results in a flare-up of that psoriasis. So if you bang your elbow on something or bang your shin against a coffee table,
Okay.
It can actually cause a wee bit of an exacerbation in that area.
Yeah.
And then other triggers would be your
Your
medications
infection?
and your infections as well.
So particularly your streptococcal and HIV.
Yep.
And
So I guess the HIV especially weakens your
Immune system.
Yeah, whenever you do kick off.
And medication, so your sense of lithium, beta blockers, ACE inhibitors, antimalarials.
And there's a big old list.
There's a big old list.
So we'll go through those now. What drugs in particular exacerbate? So beta blockers, lithium,
antimalarials, and that's your chloroquine and hydroxychloroquine. Yeah. And your NSAIDs, ACE inhibitors, and infliximab,
monoclonal antibody.
Yeah. That's the one.
Right.
And the streptococcal infection I mentioned about, it triggers guttate psoriasis.
Right, okay.
That's something we're going to get into.
We'll go through the main types.
Main types of...
No?
Yeah. Yeah.
So, 6 main types.
Yeah.
Okay. So chronic plaque psoriasis is one. Erythrodermic psoriasis.
Is 2.
Pustular psoriasis.
Is 3.
Palmar-plantar psoriasis.
Is 4.
Guttate psoriasis.
5.
And flexural psoriasis.
Ooh, flexural psoriasis. What? How do you differentiate flexural and eczema?
Well, we shall.
We'll find out.
We'll find out.
So, will we start off with chronic plaque psoriasis?
Yeah. So this is your very typical psoriasis.
Mm-hmm.
So symmetrical, well defined. You'll get salmon pink plaques on your extensor sites.
Salmon pink plaques.
Yeah.
I remember this from some of the questions.
Yeah,
you know.
So salmon pink plaques, on the elbows, knees. You know, those extensor sites.
Oh yeah. Eggs.
No
flex. Psoriasis.
See the eczema podcast for that reference.
Link up here. Thick silvery scale.
So your typical sort of appearance of psoriasis. So then you also get what's called an Auschwitz sign, which is when the scale is removed, this leads to pinpoint bleeding. Oh,
so whenever they surgically or
when they take off, when the plaque
scrape it off, or when they take it off,
that tiny little bleeding dots.
Okay. And that's called the Auschwitz sign.
Auschwitz sign.
Auschwitz sign.
Aye. And basically, is that German? Could be German.
It could be.
I don't really know.
Yeah. And the main sort of treatment for those is like your vitamin D analogues, such as your calcitriol.
Interesting. Didn't know that.
Calcitriol. Yeah. Tar preparations, UV light, and topical steroids.
Yeah. So that's only to deal with your
flares.
Yeah.
And your systemics, your methotrexate, cyclosporin, biologics. We won't go into detail for those.
Yeah.
But just remember, vitamin D analogues, tar preparations, UVB.
Okay. Nice.
UVB.
Light. UV light.
UV.
It's the type of UV light because there's
there's UVA, B, and C. Is there a C?
I don't know.
I don't know.
It's been a while since we've done physics, you know. Already.
I can find out the answer and just put it in.
Erythrodermic psoriasis then. So this is when this is a more severe version.
It's not a pretty picture.
No, so this is when it's skin deep psoriasis that approximately can cover up to more than 90% of the body.
That must be hard for the patients.
Yeah, it does not seem very pleasant to deal with.
Yeah.
And it can be quite scaly as well, and normally patients will also be unwell and have like a fever and like general tiredness with it. And there could also be triggering factors for this that could crop up from the history.
Okay.
So complications of this is you'll have a decrease in your thermoregulation.
That's because you're losing.
Yeah, you're losing that
top
barrier.
layer.
Yeah. So like your ability to retain fluid and proteins is going to be a bit disrupted.
And the fluid loss can trigger like high output heart failure. Basically. Yeah.
And then you can also, of course, get infection
because the barrier's kind of
broken up a wee bit. Yeah.
present.
Exactly. So treatments for this is mainly just supportive fluids.
Mhm.
So you need to replenish the fluids that are being lost, and then also emollients and skincare in general need to be used, because I guess you need, like we've mentioned in the eczema video cast. It's catching on, actually. I quite like that term. The video cast one.
The vidcast.
The vidcast. You know, you need to fill in those gaps. In the skin.
Yeah. And then we have pustular psoriasis, which is, it's like an extensive sheet of pustules.
Mm-hmm.
What are pustules, Chris?
They're fluid-filled sort of.
They're like wee
on
pimples kind of thing. Yeah, fluid-filled.
Yeah.
Well, it's not pimples. It's like kind of more flattened sacs. Fluid.
Aye.
Yeah,
I think so.
And it's red and painful.
Again, it's quite a severe psoriasis. So
Yeah.
patients will be
Unwell with fever.
and quite tired and fatigued.
And the mainstay treatment for those, for that psoriasis is supportive fluids, emollients, and skincare. Realistically,
Yeah, and then also
and
your
systemic therapy, such as like
that would be your methotrexate. What else? Cyclosporins, and biologics.
Yeah, biologics. That's
as well.
one. And we have your palmoplantar psoriasis, which is pretty self-explanatory.
Yeah, so palmo and plantar.
Palmo and plantar. You plant your feet.
Get your kebs out.
And you palm. Jiu-jitsu moves, Chris. Eh? Chris does jiu-jitsu, so this is how we learn. So
okay. Well, yeah.
Palmoplantar, and it's pretty much like pustules. Affects your palms and soles.
Yeah, pustules on the palms and soles that also have some erythema around it.
And it's usually symmetrical.
Can be painful.
Well,
I guess you're using your hands that much, so you're going to cause a lot of sort of friction in those areas and make it a bit more angry.
Treatment's, however, difficult, and it requires tar and potent topical steroids. And hand and foot PUVA.
What?
Puva.
What
is Puva?
You don't know what Puva is, do you?
Editor, you don't need to put the diagnosis. We're figuring it out.
We're going to do it right now.
Consultant Papa Google.
Photochemotherapy.
What?
Type of ultraviolet radiation treatment, phototherapy, used for severe skin diseases.
I thought it was phototherapy. I don't know why.
Why you did not think anything. You didn't have.
UVA, bro. Ultraviolet A.
Oh yeah.
Photo ultraviolet A, right?
Okay, yeah.
I
totally.
think that's what they're going for.
Yeah, totally.
Aye. And then
you talk some rubbish, pal.
Yeah. and then we have guttate psoriasis.
No, not guttate. Guttate. Guttate.
Same thing. It depends on how you pronounce it. If you pronounce guttate, comment below. If you pronounce guttate, don't comment at all.
Let's make a poll.
I don't like it.
No, guttate makes
guttate.
I hate that. Okay.
That's your wee teardrop plaque, isn't it?
Yeah, so this will come up in questions, and
someone has a streptococcal throat infection, and they're starting to have a rash that looks like teardrops.
Yeah, boom.
What is it?
Guttate psoriasis.
Guttate psoriasis.
Aye. So you just need to look for those like buzzwords of teardrop plaques.
You cry. You cry when you're hungry. Your gut. Oh, you cry when
your gut aches.
Hit in the gut, don't you? Tears,
yeah.
Tears flowing when you get.
Aye.
Yeah.
That works. Yeah.
We're not doing too well in this.
Our learning mechanisms are a bit weak today.
Well. But it can lead to chronic plaque psoriasis. No, chronic psoriasis, not chronic plaque. If it's not cleared completely, it will lead to chronic
psoriasis. Okay.
And the treatment is vitamin D and tar preparations.
Yeah. And then you can also use your UV phototherapy. UV.
And they tend to usually
they respond very well.
They respond very well to it. Yeah.
Yeah. And this is very common in teenagers as well.
Yeah. And then now we have the coolest one, flexural psoriasis.
Yeah.
It affects the axilla, submammary, and groins region. What's submammary?
Submammary is like underneath the breast, I think, or pectoral muscles.
Pectoral.
Yeah, but I think it's typically underneath the breast, and this is very well defined red
with minimal scale.
Yeah, red sort of rash.
It's kind of like it's highly you can see it. It looks very angry.
Yeah.
And
so I don't think you could I feel like you wouldn't really be able to mistaken this for eczema. Like it happens in those flexural areas, the axilla, and like groin areas and your submammary areas.
Well,
but
you can mix it up for seborrheic dermatitis and
okay.
intratrigo.
Try it again.
Intertrigo. Wow. That's cool. And the treatment option for this is steroids and antifungal mix. And you can also use topical calcineurin inhibitors.
Yes.
Which is what?
They're vitamin A.
Which is what?
Oh, the names of one. Tacrolimus, isn't it?
Good man. And what was the other one?
Begins with a P and ends with limus.
Something limus. Piccolo limus, maybe?
Piccolo
It's not piccolo limus. It's something.
Piccolo
limus.
But yeah, this is the flexural psoriasis commonly has a secondary candida infection.
Something to remember about in questions.
You will then get a satellite lesion away from the plaque. So this is like a separate circular lesion
entity
away from the rest of the rash.
Okay.
But yeah, and
something
that's
to look over.
Yeah, that's why you can give the antifungal mix as well, isn't it?
Yep. And so now we've covered all types of psoriasis. We're going to talk about the complications that can arise from psoriasis, which is like your we'll start with psoriatic arthropathy.
Yes. So what is that?
It is pretty much what it says. You have psoriasis and you get like arthropathy.
Yeah, you get a sort of pain in your joints.
Yeah.
This can happen 5 to 30% of patients with skin disease.
And it's often asymmetric.
Yep.
And it can affect large or small joints. And can also affect sacroiliac and spinal joints.
There we go.
Good to know.
Interesting. So then the next one is psoriatic nail dystrophy, which is your sort of classical changes of pitting, oncolysis and oil drop. So oncolysis is like separation of the nail from the nail bed, and it makes it look a bit yellow and stuff, isn't it?
Yes. And
the pitting is like dips in the nail bed,
in the nail beds,
or in the nail itself, and oil drop. What's that?
Oil drop is what it says.
Oil drop.
Consult Papa Google again.
Let's see.
I have no idea what oil drop is.
Psoriasis. It's gonna be like maybe it's like excess dryness around it.
Oh. Okay.
And do not usually have.
So it looks like trapped oil underneath the fingernail.
So causes the whole nail to become thick, discolored, and crumbly. Yeah. Okay. And it can be commonly misdiagnosed as a nail fungus. Interesting.
Yeah. And secondary onychomycosis is the fungal infection you get from psoriasis.
Okay. Treatment. Very difficult to treat this. And you would use topical steroids. Or vitamin D.
Yeah.
And then you can also use systemic agents as well. So then next on our complications is psoriatic scalp disease. This can be extensive and cause significant distress. A lot of severe itching. It can get very angry. You can see it kind of outline the edge of your hair.
Yes. It's most people you can like about it is it depends on like it affects different people differently. I guess.
I guess it depends how angry it's looking.
And the treatment. It is also very difficult to treat. These kind of complications are quite difficult to treat.
Yeah.
Like steroid shampoo or gel, tar shampoo. Then you can also use oil to remove the scale.
Okay, so you can use olive oil and coconut oil
and
for that.
Coconut oil.
Okay,
yeah.
And then
there's no harm in using it like normally as well.
Yeah.
Like it's very good for your hair.
Oh, is it? I might give that a go.
Pretty sure coconut oil is pretty good for your hair. I don't know.
Comment if you know any.
Any good hair tips, because Chris takes like 5 hours to get his hair done in the morning, so
it looks good though. So
it does look good.
Shake your head. How dare you?
So we're gonna focus on the management of psoriasis now.
Well, no, we need to cover the last complication, which is metabolic syndromes, which is it can cause significant increased risk of cardiovascular disease. Basically, that's only a wee small note at the end. But we did say there were 4 complications. We can't.
Did we say 4?
No, I did.
I don't remember saying 4, but okay, there you go.
I remember
metabolic syndrome.
It was in my head. I remembered it.
So the management of psoriasis.
I'm keeping you guys in the loop. Don't worry.
Yeah,
he isn't.
It's a step by step. I'm trying to do the vidcast here. Do you want to, like,
Okay, apologies.
Yeah.
Go on ahead. Go through your management.
So my management, right, for chronic plaque psoriasis
It's
is,
not your management. It's nice guidelines management.
well, NICE recommends very nicely that a potent corticosteroids applied once daily plus a vitamin D analog
Once daily as well as a
for
first line.
And, well, obviously you need to use the regular emollients anyway.
Mhm.
Like, just keep that in the background there.
Yeah.
And it should be applied separately once in the morning and once in the afternoon.
Okay, so you split it up between the two.
Not the afternoon, the evening, yeah.
Yeah, so you'd take your corticosteroid in the morning and then use vitamin D analog in the evening. Is that what that,
Yeah,
that's
yeah.
what that means? Yeah.
Yeah.
Okay.
And then your second line is if there's no improvement after 8 weeks. So you tried this, the first line, for 4 weeks,
Okay.
and then after that, if there's no improvement after 8 weeks, then offer vitamin D analog twice daily,
Twice daily. Okay.
and you forget
Okay.
about the corticosteroid there.
Oh, okay. Okay.
And then third line, if no improvement after 8 to 12 weeks, then you offer the corticosteroid twice daily for up to 2 weeks.
For up to
4 weeks. Sorry,
Yeah.
my fault. Or cold tar preparation applied once or twice daily.
Okay.
So you choose
okay.
between those two.
Okay, so that's up to your third line, and then your
And then
secondary
yours.
care management is using your ultraviolet light phototherapy, and this should be given 3 times a week. And then you can also go into your PUVA, your photochemotherapy, which we just learned today. Go us! But the adverse effects to this is skin aging and increased chances of squamous cell cancer, but not melanomas.
Okay.
Okay.
So it's a narrow band ultraviolet B, isn't it?
Yes, narrowband ultraviolet light B.
Okay,
Yeah,
that's
but yeah.
interesting.
Okay. But yeah, and then we can also go through a wee bit of the systemic sort of treatments. So you would use your methotrexate, which is your DMARD, your disease modifying what's the DMARD stand for? DMARD.
It's okay, I got it. Papa
Off-
Google.
Off the top of my head.
It is disease modifying anti-rheumatic
drugs.
Yeah.
I thought it was anti-rheumatic, but I wasn't
Well, like,
confident. I should have just stepped with my
You
confidence.
thought it was. Yeah.
I didn't say it.
Yeah, exactly.
Okay. So that's good for your skin and joints. It is, however, immunosuppressive, and it can cause risk to your liver, so you need to keep an eye on the patient's LFTs when they're doing this.
We're going through the systemic ones. now, are we?
Yeah. I literally said that. You don't even pay attention to me.
I was
You're-
gone on
you're-
DMARDs, bro.
You're
You said DMARDs, and I
You're-
was thinking about DMARDs.
Aye, I'm sure. But yeah, so cyclosporin we also mentioned, which is another immunosuppressant medication. This only affects the skin, and it also has renal complications, so keep an eye on the UNEs for that. And then you have your vitamin A analogues,
Which is called
acitretin.
acitretin.
Aye.
Acitretin.
And this typically has lower success rate than the previous two mentioned. And then finally, we did mention biologic agents, which is your anti-TNF or anti-interleukin 23,
12,
22.
23, and 27, bro.
Aye, go you. These are all immunosuppressive, I guess. You know.
What can I say? I'm just good with numbers.
Yeah, you're good with numbers. Pretty sure in another podcast we said numbers weren't your strong suit as well.
BD4. Well, I've learned from that mistake, haven't I? Yeah.
You've turned it around, have you?
BD4 inhibitor, which is your so many A stuff like
apremilast. Oral, taken orally, and it is non-immunosuppressive.
Yeah, I actually want to check at the NICE guidelines for the treatment options, because like,
well, that's your systemic stuff. You start using that like really like last line. You know, once you've gone through your first, second, and third line stuff. So yeah, that's.
yeah. So
Yeah.
That's way too confusing.
We've got it right.
Yeah, we've got it right.
Yeah.
Just I was having second doubts about myself, but
Don't doubt yourself, bro.
It's all
Okay,
good.
you don't need to doubt yourself. It's
But
fine.
yeah, that's pretty much us for
That's this episode, isn't it?
today. Yeah,
Aye,
yeah, of course.
class. So covered psoriasis.
Yeah.
We'll
If you have any questions,
stick it
comment
in
below.
the comment
and,
if you want
we'll-
any topics covered in our weird, ill-informed
Vidcast,
way.
yeah.
We can do that. So again, like, comment, subscribe, and we shall see you in the next vidcast. Okay, peace out, guys.
Peace out.
Bye.